KT is a 50-year-old woman presenting to the emergency room with intractable nausea, emesis, and a progressive inability to tolerate oral intake. Her initial vitals show a heart rate of 110 beats per minute, tachycardia, and a blood pressure of 105/70. She is pale, diaphoretic, and clutching an emesis basin. She describes a sensation of absolute fullness, as if a concrete block has been poured into her epigastrium. For the past month, KT noticed a subtle but relentless shift in her physiology. It began as a casual disinterest in breakfast. Then lunch became unappealing. By the third week, the mere olfactory detection of food triggered a visceral repulsion. This was not a stomach bug. This was a systematic shutdown of her gastrointestinal motility. KT had recently begun a regimen of a glucagon-like peptide-1 receptor agonist, or GLP-1RA. She did not obtain this pharmaceutical from a licensed physician. She acquired a surplus supply from a friend, bypassing the titration schedule, the critical ramping up of dosage intended to acclimatize the body to the potent endocrine shift. She started at a therapeutic maintenance dose, shocking her metabolic system. The human stomach is a muscular sac, a J-shaped organ designed to churn and liquefy boluses of food into chyme. It accomplishes this through peristalsis, rhythmic contractions of smooth muscle. These contractions are regulated by the vagus nerve and the enteric nervous system. When KT injected the GLP-1 agonist, the molecule bound to receptors not just in her pancreas, but along the lining of her stomach and on the vagus nerve itself. In a healthy patient, GLP-1 signals satiety. It tells the brain, we have nutrients, stop eating. It tells the stomach, slow down emptying so we can absorb this. But in KT, the overdose of the agonist caused a catastrophic deceleration. The smooth muscle cells of the gastric antrum entered a state of paresis, gastro meaning stomach, and paresis meaning paralysis. Her stomach didn't just slow down, it effectively stopped. As KT continued to force small amounts of food down a paralyzed tract, the undigested matter began to accumulate. Vegetable fibers, proteins, and gastric mucins began to knit together, layer by layer, forming a concretion known as a bezoar. This solid mass acted as a ball valve, physically obstructing the pyloric sphincter, the exit door of the stomach. In the emergency room, KT reports a new, terrifying symptom, dysgeusia, dys meaning bad or difficult, and geusia referring to taste. A sour, metallic fluid is regurgitating into the back of her throat. This is fermenting gastric acid, unable to move forward, moving backward. A CT scan of her abdomen reveals the magnitude of the stasis. Her stomach is distended, filled with a heterogeneous mass mixed with pockets of gas, the bezoar. But the scan reveals something more alarming: massive fecal loading in the colon and a dilated common bile duct. The biliary tree, the network of tubes carrying bile from the liver and gallbladder to the intestines, is swollen. Usually, biliary dilation indicates a stone, cholelithiasis, chole meaning bile, lith meaning stone, and iasis meaning a process or condition. But KT has no stones. The diagnosis is functional biliary sphincter of Oddi dysfunction, caused by the systemic paralytic effect of the medication. The drug has relaxed the smooth muscles so profoundly that the bile simply sits there, backing up into the liver. Blood work reveals acute kidney injury. Her BUN, urea nitrogen, and creatinine are elevated. Because she cannot keep water down, her intravascular volume is depleted. Her kidneys are starving for blood flow, leading to pre-renal azotemia. azot meaning nitrogen, and emia meaning presence in blood. She is effectively poisoning herself with her own metabolic waste because her filtration system has lost its hydraulic pressure. The medical team faces a dilemma. Mechanical extraction of the bezoar via endoscopies carries the risk of esophageal perforation. Surgery is invasive. They opt for chemical dissolution. They administer 3 liters of carbonated diet soda over 12 hours. The carbonic acid and the mechanical action of the bubbles work to penetrate the interstices of the food bezoar, breaking the mucin bonds holding it together. It is a primitive but effective solvent. Simultaneously, the GLP-1 agonist is discontinued. The half-life of the drug must pass. As the chemical washes out of her receptors, the vagal tone returns. The smooth muscle repolarizes. Peristalsis flickers back to life. Following the soda lavage, KT experiences a massive evacuation of the bowel, the mass effect clearing. Her gastroparesis resolves, but the metabolic insult serves as a permanent warning. JC is a 34-year-old male presenting to the ER with excruciating, terebrating abdominal pain radiating directly to his thoracic spine. He is tachypneic, taking shallow, rapid breaths because deep inspiration compresses his diaphragm against an inflamed abdomen. He is vomiting bilious material, green fluid, indicating the obstruction is below the stomach, likely near the duodenum. JC, seeking aesthetic refinement, obtained GLP-1 agonists via an online telehealth service. He combined this therapy with his regular lifestyle, which included moderate alcohol consumption and the use of prescription opioids for chronic knee pain. Blood analysis reveals hyperlipemia, hyper meaning high, lip referring to fat or lipid, ACE denoting an enzyme, and emia meaning blood presence. Lipase is an enzyme synthesized by the acinar cells of the pancreas to digest dietary fats in the intestine. It should never be in the blood in high quantities. Its presence indicates that JC's pancreas is leaking. The pancreas is a volatile organ. It stores digestive enzymes as zymogens, inactive precursors. They are only supposed to activate once they hit the duodenum. However, the GLP-1 agonist stimulates pancreatic beta cells to secrete insulin and simultaneously suppresses glucagon. Historical data suggests GLP-1 can also induce hypertrophy of the pancreatic ductal cells. In JC's case, the combination of the medication, the opioids, which cause spasms in the sphincter of Oddi, and the alcohol, which is directly toxic to acinar cells, created a perfect storm. The outflow of pancreatic juices was blocked. The pressure within the pancreatic duct spiked. The zymogens, trapped inside the gland, prematurely activated. Trypsinogen became trypsin inside the pancreas. This is acute necrotizing pancreatitis. JC's pancreas is digesting itself. The enzymes meant to break down a steak dinner are now liquefying his own retroperitoneal organs. The cellular destruction triggers a massive immune response. Cytokines, chemical signaling molecules, flood his bloodstream, causing systemic inflammatory response syndrome, or SIRS. His capillaries become leaky. Fluid weeps from his blood vessels into his abdominal cavity, causing ascites and further dropping his blood pressure. This hypoperfusion hits his kidneys and liver, initiating multi-organ failure. A CT scan shows a terrifying development: gas pockets within the pancreatic bed. The pancreas is not a hollow organ. It should not contain gas. This finding, emphysematous pancreatitis, suggests that bacteria have translocated from his paralyzed gut into the dead pancreatic tissue. He is septic. The medical team initiates aggressive fluid resuscitation, liters of lactated Ringer's solution to maintain perfusion pressure to the kidneys. They place him on bowel rest, inserting a nasogastric tube to decompress the stomach. Pain management is tricky. Opioids could worsen the sphincter spasm, but the pain is incompatible with life. For days, JC hovers on the brink. The inflammation creates a pseudocyst, a walled-off collection of necrotic enzymatic fluid. The body attempts to encapsulate the acid burn. Fortunately, the antibiotics and aggressive supportive care arrest the bacterial translocation. The necrosis stabilizes. He avoids surgical debridement, a procedure where surgeons must physically scoop out dead pancreatic tissue by the narrowest of margins. Both KT and JC represent the statistical outliers, the black box warning. The mechanism of action for GLP-1 agonists is rooted in the biology of the Gila monster, Heloderma suspectum. The lizard produces Exendin-4 in its venom, a peptide that slows metabolism and regulates sugar during months of starvation. We effectively biohacked this reptilian survival mechanism for human weight loss. While these drugs offer profound benefits for millions, reducing visceral adiposity and cardiovascular risk, they are potent endocrine modulators. They alter the fundamental pace of the gastrointestinal tract and the secretory rhythm of the pancreas. When combined with other factors, opioids, alcohol, lack of medical supervision, the therapeutic window creates a draft that can slam shut on the fingers of the patient. JC makes a recovery, but his pancreas is scarred, fibrotic. He carries a higher lifetime risk of diabetes and malabsorption. His lesson, written in the scar tissue of his retroperitoneum, is that biology is a balance of inputs and outputs. There is no biological free lunch. Every metabolic acceleration or deceleration extracts a toll.